Hello, and welcome to a spotlight on Rett syndrome, delayed diagnosis, patient caregiver perspectives, and evolving treatment. I'm Dr. Jeffery Neul. I'm the director of the Vanderbilt Kennedy Center and Annette Schaefer-Eskin Chair in the Department of Pediatrics at Vanderbilt University Medical Center in Nashville, Tennessee. Today, I have a colleague joining me. Would you like to introduce yourself?
Yes, I'm Alan Percy. I'm a professor emeritus of pediatric neurology at the University of Alabama at Birmingham and the Sarah Catherine Beta Endowed Professor. The learning objectives of this talk are to identify the early signs and symptoms of Rett syndrome and recognize the impact of delayed diagnosis on patient outcomes, to incorporate patient caregiver perspectives into clinical decision-making for Rett syndrome, and to assess how new and emerging treatments may help address current limitations in the management of Rett syndrome. First, we'll talk about the diagnosis of Rett syndrome. We're going to begin with a case. In this case, we'll go through some stages. Amelia at this time is a 3-year-old girl referred to our child neurology clinic with the following history. She had a normal early development through 6 months of age, but after that experienced some delays in development. Her head circumference was growing normally through the first 6 months, but after 6 months, she had an abnormal decline in the rate of head circumference increase. In terms of communication, she had single words at 12 months of age, but lost these at 34 months and continues to babble. Hand skills, she had a finger feeding with pincer grasp at 1 year, but lost this pincer grasp at 3 years of age. And in the meantime, she developed hand stereotypies with hand clasping at 2 years of age and hand wringing movements at 3 years of age. Her walking was also delayed. She walked with support at 18 months and alone at 35 months, but lost the independent walking 1 month later.
So I think this is a really interesting case because I think it's interesting to think about how you would determine whether Amelia has Rett syndrome. So I think we can first start with discussing what are the clinical criteria for Rett syndrome. Well, first, there's a typical disease progression, and what that involves is apparently normal initial development of psychomotor skills, but then followed by a regression of some acquired skills and then stabilization of those skills. And specifically, there's a loss of purposeful hand skills and a loss of spoken language. Additionally, people with Rett syndrome have gait problems or are unable to walk, and they have characteristic repetitive hand movements. So, Dr. Percy, can you go over Amelia's signs and symptoms and reflect on that compared to the diagnostic criteria for Rett syndrome?
So certainly, as you described, and for Rett syndrome, Amelia had an apparently normal development during infancy, but very quickly after 6 months of age demonstrated a developmental delay. She did begin speaking words, but lost that ability at 34 months of age. She partially lost hand skills at 3 years of age and independent walking at the same time. And the hand stereotypies began at 2 years of age. So I believe that Amelia clearly met the clinical criteria for Rett syndrome.
Yeah, it really seems like she fit the pattern very well and met all the criteria. So there are different stages of Rett syndrome. The first stage, or early onset with delay, is really in the first year and a half of life, where there's apparently normal development followed by delay, which may be subtle and within the reference range. The next stage, when most people are identified as having the disorder, is the regression stage, or stage 2, which occurs between a year and a half to maybe 5 years of life, where there's a loss of hand skills and spoken language, which may be partial. There's the onset of the repetitive hand stereotypies and gait problems. After regression, it could be 5 years old, about you have the plateau stage or stage 3. And this continues on up until the teen to adult years. And there's a stabilization of the skills, and there's the development of other medical features such as seizures, breathing abnormalities, progression of motor abnormalities. Finally is stage 4, which might start in the young adult years and continue on, which is late motor deterioration. And there's increased rigidity, decreased mobility, and the onset of Parkinsonian features. So let's review the epidemiology and genetics of Rett syndrome. So it is primarily, but not exclusively, found in girls at a frequency of about 1 in 10,000 live female births. The majority, about 95% of people who meet the clinical criteria for Rett syndrome have mutations in this gene, methyl CpG binding protein 2, or MECP2. They are de novo mutations in most cases, meaning they are not found in either mom or dad, and it is not seen multiple times in a family. But there are some rare cases that it is. About 5% of people who meet the clinical criteria for Rett syndrome do not have mutations in this MECP2 gene. Now, there are boys who have mutations in MECP2, and oftentimes we had seen them as having severe congenital encephalopathy, meaning they were markedly impaired from the time that they were born. However, we're learning more and identifying more boys who have MECP2 mutations, and some of these boys do meet clinical criteria for Rett syndrome. So there are boys who have Rett syndrome. Now, some of the things to consider for reasons and the impact of a delayed diagnosis are that the early signs and symptoms may be missed. So as we mentioned, it seems to have apparently normal early development, but there may be mild hypotonia, and families often report that their child is too good. It doesn't arouse well, or sleeps a lot and seems very placid, or doesn't make much noise. And then this early sign of a decline in the rate of head growth with a relatively normal head size or normal head size at birth, but slowly starting to not keep up with the normal rate of growth. The developmental delay may be subtle and not outside the reference range. Oftentimes we hear that the family's reporting that the child is not walking at the same time as a sibling, but it's still within the range of a normal reference, so it's not rising to concern for clinicians. Some of the skill loss may only be partial. They may not gain spoken words, but they'll lose their babble or vocalization. And even though there can be this decline, oftentimes there is a decline in the rate of head growth, the head growth may still remain within the normal range. The other reason for delayed diagnosis is this male sex, with the misperception that only girls can have Rett syndrome. Now, delaying this diagnosis adversely affects starting early intervention and initiating medical monitoring for known problems that are involved in Rett syndrome. Some suggestions to avoid delays in diagnosis. For the parents, being attentive to developmental progress, and particularly being too good, persistent with the healthcare providers if the progress is not ideal. So the parents should be, strong advocates, and the healthcare providers should be listening to their concerns. For the healthcare providers, they should be good listeners and forceful in seeking advice from subspecialists or additional diagnostic testing, and not only focus on females. Pay close attention to the growth parameters, especially the rate at which the head is growing. Information is available about Rett syndrome from patient advocacy groups, such as the International Rett Syndrome Foundation, which can be found at rettsyndrome.org, or the Rett Syndrome Research Trust. Also are valuable is interacting with the Rett Syndrome Centers of Excellence that are found across the country.
If we go back to the case, Amelia met the clinical diagnostic criteria for Rett syndrome, and she was given this diagnosis at 3 years of age based on those clinical criteria. Genetic testing was performed and identified a pathogenic variant in MECP2 or MECP2, This was a fairly large deletion at the terminal end of the gene, which is one of the more common deletions seen in girls with Rett syndrome. So there are key takeaways from this section. Rett syndrome is a progressive neurodevelopmental disorder. Rett syndrome remains a clinical diagnosis inasmuch as not all girls who meet the clinical criteria have a mutation in MECP2. And there is a characteristic pattern of the disease with regression followed by stabilization. Early features before regression may be subtle, and developmental delay may not be appreciated fully by either the family or the physician. Mostly in girls, but it does occur in boys, and the physician must be keen to remember that this is a potential diagnosis in boys with substantial developmental delay. The majority of affected individuals have mutations in MECP2, as I said, but not all people with Rett syndrome have an identified mutation. Symptomatic treatment is essential. Now let us move on to incorporating caregiver perspectives in clinical decision-making. And it is critical to consider the point of view of the parents and the caregivers. Let's come back to Amelia. Her disease has progressed. She developed feeding issues at 4.5 years. Her BMI was at the 75th percentile, but fell below the 25th percentile over 2 months, a rather substantial loss of weight. Meal times increased to 1 hour with very poor chewing and swallowing, and the onset of frequent choking. At this time, she had no seizures or breathing issues. She was now reaching for objects only with her right hand and walked only with support. She had begun to communicate with an eye tracker assistive communication device. Subsequently, she had a gastrostomy tube inserted with fundoplication to address problems with chewing and swallowing and the growth failure. And the fundoplication was performed in order to reduce problems of gastroesophageal reflux. Rett syndrome is a lifespan disease, and it has different features across time. Early on, there needs to be an attention to growth, nutrition, and GI issues. In later childhood, after the regression has ended, multi-system issues begin. This could include seizures, gastrointestinal issues, including not only GE reflux, but also delayed stomach emptying and constipation, breathing issues, and perhaps the early signs of scoliosis. By adolescence, puberty has been noted. Scoliosis has progressed potentially, significantly, and seizures remain a problem. Attention to nutrition is also important, not only to be certain that the girl maintains adequate growth, but also that based on her level of activity or inactivity, her weight does not increase disproportionately. During adulthood, post-school daycare becomes a problem. In this country, most girls or women are able to go to school up to the 22nd birthday. But after that, they lack the services that are provided in school, and so it is important to consider what can be done for the older woman with Rett syndrome. Bone health is a problem as well, as we know that osteopenia and in some cases osteoporosis is a problem, and attention must be given to this. Incidence of non-traumatic fractures can be substantial, as high as 25 or 30%. And there is a persistence of motor issues as the muscle tone becomes more increased or rigid, and the features that were mentioned of Parkinsonian-like disease become present. Lifelong, there's a need to assess therapy programs, physical, occupational, speech language, and use as best possible augmentative communication. Later on, it's important to determine whether or not a group home or other care provider is required, as the parents may become unable to care for their daughters, particularly as they grow and age up through 50 or 60 years of age. At least by the time they're 18, guardianship and conservatorship need to be discussed with the family and need to be obtained, which require legal help. And throughout the school years, it's important to evaluate their current individual educational plan. So the consensus guidelines that have been put together by Carrie Fu and other members of the physician group working with Rett syndrome are critical. These promote integration of care across a range of primary and subspecialty providers. We regard the primary care provider as a quarterback who should be seeing these girls on at least an annual visit in any acute care requirements. It's important to review general health, medication, and allergies, check growth, including height, weight, head circumference, and Tanner staging. And it's important to emphasize the need to check the head circumference. It is typical to measure head circumference up through 2 years of age, but it's also useful to assess that periodically up through age 10 at least. A number of lab tests are important, particularly the vitamin D level relating back to bone health, as well as an electrocardiogram because of the potential for prolonged QTC interval. This has been noted in up to 20% of individuals with Rett syndrome. And if the QTC is elevated, referral to a cardiologist is indicated. Physicians need to recognize the need for extra time due to the complexity of the issues related to Rett syndrome and to answer the questions that the caregiver may have. It is critical that the parents and/or caregivers maintain a binder to include all health records, clinic visits, genetic testing, and other assessments related to their daughter's diagnosis, or in the case of a son, to their son's diagnosis. Specialty referrals are indicated and include both the neurologist, gastroenterologist, epilepsy expert in some cases, orthopedist, and those specializing in sleep, endocrinology, or behavior.
Well, I think that video, the caregiver brought up a lot of really important points to think about. The emphasis on how important it is to listen to the caregivers and to value what they're saying and how the impact of medical and interventions have on them, their children, and their families is a very valuable thing to be thinking about with Rett syndrome.
Yes, Rett syndrome for the caregivers is a 24-hour-a-day occupation, and they spend an enormous amount of energy with a variety of features that their daughter may have. So it is critical in your very brief assessment, which in our case is often an hour or two, but still it is only a fraction of the caregiver and the girl's life. So it is critical to listen to the caregiver, listen and really address the patient. I look into the patient's eyes, and I can say that in most cases, they recognize me after they've seen me once or twice. So it is key to make them understand that you are listening and paying attention to what is being told to you.
It was nice to hear the comment about the notion from the caregiver of this multidisciplinary team and the challenges of coordinating across a bunch of specialists who are experts in their own area, but not necessarily integrated with all the other aspects of Rett syndrome that these caregivers and the affected individuals are dealing with. And The comment about the aspects of things like sleep disruption or screaming and hyperventilation are things that, come at different times and not during clinic visits. So you just have to listen to what they're saying, and make sure you're acknowledging and incorporating that into how you're approaching the management of this person.
Looking at the engagement, the education, and the empowerment of caregivers, it's critical to recognize that the caregivers are not trained clinicians, but they are reasonably intelligent and good observers. So you need to engage the caregivers by asking, how are things at home? What are you doing? What are the concerns? How could things be better? And then educate the caregivers. Give instructions that are useful and understandable, and advise them on how things can be learned through a variety of techniques. And finally, one quote is, Rett syndrome is a marathon, not a sprint. It's a lifelong disease, and it changes over time. So it's important to answer the question related to the age of the individual and the problems that they have. So that, for example, in the 3-year-old, communication and early childhood education and perhaps even early therapies are critical, but questions about puberty or older adulthood are not really relevant at that time. So be available to answer questions that may come up after your clinic appointment and be responsive to those questions. And this takes a critical look at the top concerns that caregivers experience. In our natural history study for Rett syndrome, over a large number of individuals, we had these top 5 concerns. And by and large, the lack of effective communication was the greatest concern for caregivers. The inability to understand what it is that their daughter wants or their daughter is trying to tell them. Seizures are important. A lack of hand use and ability to walk are also important. And interestingly enough, constipation is an ongoing problem, which can vary from day to day, depending on a number of factors, including their diet and their amount of fluid they take in. Incorporating the caregiver perspectives is critical. It cannot be overemphasized how important the caregiver is. They offer perspectives that one cannot capture in an office visit, and it's critical to pay attention to their specific concerns. It is really unfortunate if one ignores these concerns. And the caregiver concerns may be modified from day to day by new events, including seizures, gastrointestinal issues, scoliosis, and behavioral issues such as anxiety or aggression or even depression. In terms of the case, let's circle back. The parent mentioned that there was a change in her feeding pattern and weight loss. Attention to these led to appropriate studies to determine the reasons, which included a swallow study and an upper GI evaluation. This resulted in an insertion of a gastrostomy button along with a fundoplication. The gastrostomy does not prevent gastroesophageal reflux, and we consider it important to do the fundoplication at the same time because coming back at a later date to do a fundoplication involves a second anesthetic exposure, which may be avoided by doing this at the first step. So the key takeaways from this section are Rett syndrome is a multi-system disorder. It needs a multidisciplinary care team. It's also a lifespan disorder with different medical concerns emerging over time. Consensus management guidelines are available, and it's critical to assess the caregiver's concerns from the outset, including delayed development and effects on head growth. And it's crucial to incorporate these perspectives and input into the management of their daughters. We'll go on to the next section, which is the management of patients with Rett syndrome, both the symptomatic treatment and the specific therapies. Let's circle back again to Amelia. She was diagnosed with Rett syndrome at 3 years of age. She had feeding issues at 4.5 years that were managed with gastrostomy and fundoplication. And at 5.5 years, had the onset of scoliosis. By 6.5 years, she had seizures, which were treated with sodium valproate, but within a year, additional medication in the form of lamotrigine was added. By this time, she was developing rigidity of her extremities, limiting her movement, and had lost all purposeful hand skills. By 8.5 years of age, her scoliosis had progressed such that a surgical repair was needed. And within 6 months, she had to have surgery for torticollis. Shortly thereafter, she developed central apnea during sleep and required oxygen throughout the night. And at this point in time, at 12.5 years of age, she has brief seizures, but they occur up to 4.5 times per week.
So as you outlined, Dr. Percy, there's a change in clinical problems that occur in Rett syndrome. And the management, as you said, for Amelia has been symptomatically based to address the seizures with seizure medicines, to address the GI problems with a gastrostomy, and address the musculoskeletal issues with scoliosis surgery. But one of the things that has been exciting is the development of new therapies for Rett syndrome. And, the initial excitement began back in 2007 when work done in Scotland by Adrian Bird showed that in a mouse model of Rett syndrome, you could reverse the problems if you turned the gene back on, even after the mice were clearly sick, and it reversed the disease course. And this really set the stage for the hope that there could be meaningful therapy development for Rett syndrome. Shortly after that work, groups in Boston treated these Rett syndrome mice with a tripeptide that's called glycine, proline, or glutamate, or glypromate, which is 3 amino acids that are derived from the amino terminus of a growth factor called insulin-like growth factor 1. So it's just these 3 little amino acids shown on the right. And it's a natural cleavage product of IGF-1. When the mice were treated with this GPE or glypromate, they improved their lifespan, their locomotor function, their breathing, and their heart rate. With the evidence that glypromate or GPE could improve features in the Rett mice, there became an interest in evaluating trofinetide in people with Rett syndrome. Trofinetide has the same structure as GPE, except it has a chemical modification, a methyl group placed on it. And this improves the drug quality of trofinetide in terms of it being better absorbed by taken by mouth and having a longer half-life or time that it's in the body. So making it easier to administer by mouth and less frequently during the day. 2 phase 2 trials of trofinetide in Rett syndrome were conducted, and they demonstrated both safety and efficacy of trofinetide in Rett syndrome. This led to the initiation of a phase 3 study of trofinetide in Rett syndrome. And this slide shows the design of this study. Ultimately, 187 girls and women between the ages of 5 and 20 years old who had Rett syndrome were included and randomized on a 1-to-1 basis, either being on trofinetide or being on a placebo. And this was a double-blind treatment. So neither the physicians nor the caregivers knew which group the participant was in, and it lasted for 12 weeks. And at that time, people were permitted to enroll in an open label extension study. So that would continue the people who were on trofinetide to continue on trofinetide, and the people who previously were on placebo were offered the opportunity to be on trofinetide. This phase 3 study had co-primary efficacy endpoints. Now, the co-primary endpoints of this phase 3 study was a caregiver scale called the Rett Syndrome Behavior Questionnaire, or the RSBQ, and a clinician scale called the Clinical Global Impression of Improvement. Now, the RSBQ assesses a wide variety of symptoms and problems that are seen in Rett syndrome. There's a total score and 8 subscores. Here are the subscores. So you see there is behavioral issues about mood and anxiety, but there are also other features like breathing problems, hand behavior, body rocking, and walking and standing issues. So issues that are important in Rett syndrome. The Clinical Global Impression Scale is a clinician's view of overall change from baseline, so compared to when they first started the trial. And there are Rett syndrome-specific anchors that have been developed to guide the raters. And in this scale, 4 means there's no change from baseline, and 3, 2, 1 means there's an improvement, and 5, 6, 7 means there's worsening, with lower scores being more improved and higher scores being worse. Here is the result from the phase 3 study showing the efficacy of trofinetide on the co-primary endpoints. You see on the left the caregiver scale, the RSBQ, and this is a change from baseline with the lower numbers being better. And the people who were in the trofinetide group are in blue, and the people in the placebo group are in black with a dashed line. And you see that there is a decrease in the RSBQ in both groups at the 2-week visit, but you see that decrease or improvement in the RSBQ persisted in the people who are on trofinetide, but the people who are on placebo started going back up to baseline. So that's where the difference was that was significant, with the statistics shown below the graph. For the clinician scale, the CGI-I, you see that by 12 weeks, you had a split between the people on trofinetide, with the lower number being better compared to the people on placebo. And the statistics are shown there on the bottom. So it met the co-primary endpoints for efficacy. What are the issues that emerge, what are called treatment emergent adverse events, or kind of side effects that are noted during a trial? And there was a larger number of people in the trofinetide group, 93%, that had some emergent event, adverse event, compared to only about 55% in the placebo group. The amount of serious TEAEs was equal between the two groups. Now, in terms of adverse events leading to drug withdrawal, there were more people in the trofinetide group who withdraw because of these adverse events, 17% compared to only 2%. The majority of the withdrawals were because of diarrhea, with about 13% of the people in the trofinetide group withdrawing because of diarrhea. There was no fatalities during this. Now, the overall top adverse events was diarrhea, with almost 81% of people with trofinetide having diarrhea, compared to about 19% in the placebo group having diarrhea. Vomiting was the second most common, with almost 27% trofinetide having vomiting, compared to about 10% of people in the placebo group having vomiting. So ultimately, the combination of this phase 3 trial and the previous phase 2 trials for trofinetide and Rett syndrome recently led to the FDA-approved indication for trofinetide for the treatment of Rett syndrome. So it's approved for treatment of people with Rett syndrome who are over 2 years old. It's not intended for people who have moderate or severe kidney disease. It's a strawberry-flavored liquid that can be taken orally or through gastrostomy tube. The dose is twice a day, according to the patient's weight, with a chart there shown, and it can be delivered with or without food. Now, the most common side effects, as mentioned before, were diarrhea with 82% and vomiting, 29%. So these are important things to consider. It's recommended to stop laxatives, which are very commonly used in Rett syndrome because of the marked amount of constipation that's seen, before starting the trofinetide. It's important to interrupt or reduce or discontinue trofinetide if severe diarrhea occurs, especially dehydration suspected or significant weight loss. It's important to not repeat a dose or double the next dose if a dose is missed because of vomiting or any other reason, and instead just wait for the next scheduled dose. That's very exciting to have seen a completed phase 3 trial in Rett syndrome and now an FDA-indicated treatment for Rett syndrome. But we have a lot of other things going on, and there's emerging therapies. One of them that's being evaluated in clinical trials is blarcamesine, which is a sigma-1 receptor agonist and a muscarinic receptor modulator. And in work in Rett mouse models, it improved motor, sensory, and autonomic phenotypes. There is an ongoing trial, a phase 2 to 3 trial of this drug for 12 weeks in people with Rett syndrome. It's a double-blind, randomized, placebo-controlled dose escalation study. It includes girls and women between 5 and 17 years old who have Rett syndrome. There's ultimately now been 92 enrolled, with a primary endpoint of the change in this RSBQ score and monitoring for adverse events. Secondary endpoint being a change in the CGI-I score, evaluation of seizure frequency, and a Rett syndrome caregiver inventory assessment. Now, the primary completion date is June 2023, and it's occurring in Australia, Canada, and the UK. So we will look forward to seeing the results of this and understanding the efficacy of this therapy. Ultimately, going back to the animal work with the reversal in the mouse model has always raised the question about gene therapies. And excitingly now, there are 2 active programs evaluating gene therapy in Rett syndrome. One is called NGN-401, which is a phase 1/2 open label study to study the safety, tolerability, efficacy, and dose escalation of Rett syndrome. This was started in the United States in June of 2023, and the estimated completion is in October 2029 with 5 people enrolled, and that's for girls with Rett syndrome who are between 4 and 10 years old and occurring in the US. The other is TSHA-102, which is also a phase 1/2 open label study, dose escalating. And this began in March of 2023, and it's estimated to be completed in January of 2032 with 12 people enrolled. This is women with Rett syndrome who are over 18 years old, and this is occurring in Canada.
Let's come back now to close with a discussion of Amelia. She's now 21 years of age. She had delayed pubertal development, but began menstruation at 15 years. Like most women with Rett syndrome, remains quite small. Her weight is 26 kilograms, her height is 120 centimeters, and her head circumference is well below the first percentile at 48.5 centimeters. Her orthopedic issues have continued. She's had surgery on her left hip and knee. She had a right tibial fracture, and she's been treated for osteoporosis. She lost the ability to stand with support and to use her hands. She's quite rigid, dystonic, and has contractures at the elbows, knees, and ankles. Not long ago, she had the onset of anxiety with non-epileptogenic seizures by video EEG. And these events are not unusual for girls or women with Rett syndrome who may have events looking like seizures, but the video EEG is crucial to rule out the possibility of an epileptogenic event versus a non-epileptogenic event. She's been treated effectively with escitalopram and a serotonin reuptake inhibitor, and she continues to have 2 generalized seizures per week. On the other hand, she remains very alert, communicates effectively with her eye tracker assisted communication device. So this leads to our final takeaways. FDA approval of trofinetide represents the first specific agent for the treatment of Rett syndrome. It is for individuals 2 years of age and older. It requires a twice daily dose based on the patient's weight. Again, the most common side effects are diarrhea and vomiting, which may need attention from the clinician. And it is not intended for individuals with moderate or severe kidney disease. Additional new therapies are on the horizon, including blarcamesine and the MECP2 gene replacement. I want to thank you for your participation and wish you a good day.
I also want to thank everyone for participating in this, and I'd like to remind everyone to please remember to complete the evaluation.